Hello, good evening, everyone, and a warm welcome to another episode of our MEDtalkx live. It's 29th of September 2020. It's Tuesday night. Thank you if you're not tuning into the Bake Off tonight. We're live with you from 8 to 9 p.m. talking all things to do with ophthalmology tonight. You'll hear about the guests very shortly. I'm going to give you the phone numbers first of all if you have any questions to do with the eyes tonight. The WhatsApp number is the same as usual, 075 227 23455, and the studio hotline is 01282 723 455. Before we begin the show and I hand over to my co-host Mehran, I do want to mention that MEDtalkx, we're doing a special webinar at which one of our guest speakers tonight was also presenting on cataracts that evening, and that's between 5 to 7 p.m. The link is on the screen for those of you who are watching at home, tinyurl.com/global-health-promotion-2020. If you go on there, it's a free webinar from 5 p.m. to 7 p.m. We'd be delighted to have your company and your audience as attention that evening as well. Without further ado, Mehran, are you okay to introduce tonight's guests?
Yeah, thank you. Thank you, Fahim. So just for viewers and listeners, just remember that we are broadcasting it live on Pendle Community Radio, WAS 103.1 FM, but also we are broadcasting it live on our YouTube as well as Facebook. So do ask questions. We will put forward to our esteemed guests. So without further ado, I will start with the ladies first. So we have Dr. Mayama Muller. So she's graduated from the University of Dundee in 2008. She became a fellow at the Royal College of Ophthalmology and completed her training in the west of Scotland. She's now a medical retina consultant in NHS Lanarkshire. So she's obviously been involved in research around retinal conditions, and clearly her expertise for this discussion around eye disease is very important. So thank you, Umaima, for coming on.
Thank you for having me.
Great. And then we have Dr. Ray Radford, or I should say Mr. Radford, who's an ophthalmic surgeon specializing in cataract surgery with a wealth of experience, I think spanning about 25 years, Ray.
That's right, yeah.
You graduated from med school in Blackpool, and you've been refining your skills in cataract surgery, especially over the past 8 years. So your expertise on that would be greatly appreciated.
Thanks very much, Brad. I answered to both, either doctor or Mister. I'm not bothered.
Great. And just to be mindful, just for the listeners, the number for him, do you have the number for them to interact with us?
Yeah, the number, tonight's WhatsApp number, 075 227 23455.
Great. Okay, so I'll start with yourself, Umaima. So eye disease, if we take a step back and think about the importance of screening, why should screening be a very key area in terms of looking after people's eyes?
So I suppose one of the main areas for screening is in diabetic retinopathy. Diabetic retinopathy is one of the commonest causes of blindness in the working population. So with diabetic retinopathy, anyone who is diagnosed with diabetes will, from their GP, will get put forward to the screening program. And in the screening program, then you will have annual checks looking at the health of the back of your eyes. The reason that is important is that actually at the early stages of the diabetic retinopathy, you don't see any, as a patient, you wouldn't necessarily notice any problems with your vision. So you can have very subtle changes going on at the back of the eye that actually you would never be aware of. So prior to the screening starting, by the time patients were noticing a change in their vision or a problem with their vision, by that stage, they had already had sight-threatening disease. So with the screening program, what happens is every year the patient will go to the screening and it will have a picture taken of the back of the eyes. This is then graded by a grading team, and they will look at the severity of the disease. If you've got no disease or mild disease, you would then continue to have annual review within the screening service, or they can then increase that to 6 monthly screening. Or if they feel that actually this is somebody who needs to go and see an ophthalmologist, they will then get referred to the hospital, where we can then assess you in the clinic and start treatment as appropriate. Now, often, even when the patients come to the clinic, they won't necessarily be started on treatment straight away. Usually there'll be a monitoring period even within the clinic before actually starting treatment. But the key is really that being able to catch that disease at the early stages, where we can actually do something about it to prevent the sight loss. And that's why it's so important to actually make sure that you're attending your screening visits. Often people feel like, well, there's nothing wrong with my eyes, why do I need to go to that? But actually it's exactly why you need to go, is because we need to pick up the changes sooner rather than later. And the sooner that we can pick them up, the more that we can do to help preserve the vision.
Yeah, thank you, Mayama. If I come to yourself, Ray, so obviously diabetes is a very prominent issue for obvious reasons. I take it you have to be age 12 and above with a diagnosis of diabetes to actually be part of the eye screening program. But are there any other kind of disorders that we're trying to pick up? Because I guess early identification is the key to better management, isn't it?
If you're talking about the medical disorders, the diabetes is number one. The other big eye issue is raised intraocular pressure, and people who may develop glaucoma in the future. And the problem with the commonest kind of glaucoma is there are no symptoms. You don't know you've got it until it's very, very late. So when people are over the age of 40, over the age of 45, it is sensible to see an optician once a year or once every few years, to have someone to have a look in the back of your eye to check your pressure, to see if there could be any early signs of raised pressure or glaucomatous changes. For people with a strong family history, you can get a free optician check. I think that's still correct. But for everyone else, you should just go along and have an occasional check as you get older.
Excellent. And Ray, we have a lot of topics to cover tonight, so I want to move on to something else quite common, the concept of the dry eye. And I noticed that on your website, you do mention the different kinds of tests that the public can do. Can you tell us a little bit about how to manage such a common everyday occurrence?
So it probably is the most common thing an eye doctor will see or hear a patient talk about, and they'll talk about it in almost any consultation they have. So itchy, gritty, sore, watery, occasionally blurry eyes. There's a whole host of symptoms that people present with. And I know about it myself, because I have a dry eye condition too. And it gets labeled in a number of ways. So it can be labeled as a dry eye, or it can be labeled as blepharitis. Sometimes it's labeled, it's labeled as a watery eye. And what's going on and what causes a lot of confusion is all of those things are often exactly the same thing. And what it is, as you get older, the quality of the tear film becomes worse. So the tear film normally has 3 different components. And as you get older, those components don't work well. And the effect is that your tears will evaporate very quickly. And then you get little dry spots on the front of the eye. And because the cornea is so sensitive, the symptoms patients get ranges from nothing to mild irritation to some people complaining of severe pain. And the way your eye reacts to this, either the sensation or the dryness, is then you overproduce the watery part of the tears. So patients present with a fundamental problem of having an unstable tear film, little dry spots, but actually present as having a watery eye or a painful eye. So it causes a lot of confusion in terms of how it presents, but also when a patient comes to the hospital, the underlying condition isn't always explained fully. So they can go on for years not really understanding what's wrong and then repeat the presentation. So an unstable tear film is probably the commonest thing we see. And to make things more tricky, it can be exacerbated by the commonest treatment. So the treatment is usually artificial tears. And the cheapest artificial tears don't have a great effect. They don't last very long in the eye, but the preservatives in the tears can make some people's eyes red. So we do have patients that get into a vicious cycle of having an uncomfortable watery eye, given artificial tears that they don't understand why they're putting them in, and end up having a red eye and now an inflamed eye. And it's almost like a vicious circle. So it's important really for for doctors to try to explain more fully and slowly what's going on with patients. But there is a lot of advice online now, and that can help.
Thanks, Ray. And Umaima, are you able to just add on anything to do with eyelid hygiene, perhaps to do with blepharitis, the technical term, and just anything else that the public might be able to do for this common condition?
So for blepharitis, again, like Ray said, dry eye blepharitis, they almost go hand in hand, and they're very, very common. The vast majority of patients, even if you're seeing patients for other conditions, they will often have these symptoms as well. So the advice for blepharitis is really good lid hygiene, and that can be done with using just simple cooled boiled water, and a couple of drops of baby shampoo, or even just cooled boiled water on its own, and using a little cotton pad or a cotton ball, and cleaning the eyelashes. It's really getting in at the bed of the eyelashes that you want to try and clean, as well as that, using a hot compress or a warm compress, using that a couple of times a day, helps to soften the crusts. The blepharitis is almost like a dandruff type appearance that you can get on the eyelashes. So using the warm compress kind of softens that, and then taking away using the warm water. And it's just really simple treatment. But like Ray said, it's a common chronic condition, and patients really need to understand the chronicity of it, and the fact that it's never really going to go away, and they might have times where they need to do it twice a day, every day, and they could be doing it once a week at times, but it kind of waxes and wanes, and they need to continue with that up to some degree throughout, and that in combination with the lubricant drops, I think
the interesting thing to add there is the subjectivity of it. So some patients present and their eyes looks clear and white and calm, but when you actually test their tear film and their evaporation, so a simple thing you were saying for patients to do is simply close their eye and then open and stare and see how long it takes for their eyes to get sore. And if you have an unstable tear film, your eye starts to burn within 2 or 3 seconds. Whereas on a healthy young eye, you could sit there with your eye staring for 10 or 15 seconds and be absolutely fine. And the other important, I think, information to share with patients is, whilst it is very common, this blepharitis dry eye issue, is in that by far the majority of patients, it doesn't actually damage the cornea. You don't end up with a corneal ulcer, you don't end up with an infection. It is very uncomfortable, it can be really, really annoying, and it is very chronic, and it seems to get worse with age because your tear film composition gets worse with age. But in my experience, it rarely causes true harm to the eye.
Thank you, Ray, for that. Umaima, just kind of finishing off the dry eye topic. So as Ray alluded to, aging is obviously one of the key factors in terms of what can cause dry eyes. But is it fair to say surgery or certain types of medications can also make that complaint more prominent?
Yeah. So I suppose there are certain medical conditions where you can get dry eyes as part of that medical condition, and then there will be certain medications and things as well patients can be on, but essentially regardless of whether any of these things happen, the treatment for the dry eyes will always be more or less the same things. There's different types of drops that you can get, and there's, like Ray said, there's a preservative-free ones. There's different tear compositions that you can use, and regardless of which what the root cause necessarily of the dry eye, using the lubricants will help in all of those conditions. But then obviously if there are like medications or any other things that have contributed to that, you can look at stopping them. But as Ray said, it's not necessarily a blinding condition, having a dry eye, and it's learning to manage that rather than finding a cure for it necessarily.
Yeah, and just kind of following that conversation about the importance of eye disease, I think people do struggle. We will get Ray back. I think he's having some technical problems. But what's the interaction between eye disease as well as, say, DVLA? Because people do get concerned when they have procedures or some illnesses. Do they need to inform DVLA? What should they be looking out for?
So as a general rule, you need to be able to read a number plate at 20 meters. Okay, so as long as you're able to do that, you generally should be okay. There are so when you do a driving test, for example, that's the measure that they use. They take you to the car park and you have to read a number plate. So that's a very crude measure, but there are specific things that the DVLA stipulates, and that includes things like your visual field. So if patients, for example, have had conditions where their visual field is reduced, and that could be secondary to something like a stroke or glaucoma or having laser treatment, any of these things can constrict your visual field, and those things may be things that would stop you from driving. In that instance, the DVLA would request a driving visual field to be performed, and they can do that. Most opticians will be able to do that. And that tells you whether or not you fit the criteria for driving. Other things include things like double vision, acute loss of vision. So if you have had a new onset loss of vision, even if it's just one eye, that you cannot drive for a period of time until there's a period of adaptation. So the idea is that you need to be able to judge distances, and there's, as long as you have one good seeing eye, you're able to drive. But if you lose vision in one eye, for example, then you'll need a period of adaptation in order for you to be able to judge distances properly. Other things, so like I said, so if you've had various treatments, sometimes you would need to inform the DVLA. And the other thing to bear in mind is that the requirements for someone driving a car is different to someone driving an HGV or a bus, for example. The rules are different, and they're obviously a little bit more strict for HGV drivers or bus drivers. You know, there's the different categories. The safest thing to do is to see an optician about that, and then contact the DVLA if necessary.
Okay, excellent. We're just waiting for Ray to come back, so we'll plow on. Umaima, we've got a lot of topics. So in terms of cataracts, that's a big topic that we want to discuss tonight. Can you tell the audience what is a cataract, how does it present, and what's the treatment?
So cataracts are basically clouding of the body's own natural lens. We've all got a lens in our eye which allows us to focus the light onto the back of the eye, which is the retina. And as you get older, that lens can become cloudy. When you get that cloudiness, it becomes stiffer, and it's not able to focus the light in quite the same way. So the commonest cause for cataract is aging. And basically, if you live long enough, you're going to get a cataract. Everyone gets a cataract at some stage. There are things that can accelerate that process, and there are conditions that patients can get cataracts sooner. Things like diabetes, for example, can cause cataracts to build up sooner. Inflammation, using steroid drops or even steroid tablets sometimes can cause it. Injuries to the eye, all of these things can accelerate that process. But essentially what it is the body's own lens becoming cloudy and becoming discolored almost. So that means that it's letting in less light into the back of the eye, and the focus is not there because it's not able to change shape in the way the lens should be able to. As you said, it's the commonest thing, and so everyone should attend their optician on a regular basis, and the opticians will, they're very good at picking up cataracts. But the thing that's important is that you get referred to the hospital for consideration of surgery when it's starting to impact on your vision, and that will be different for everyone. So there will be some people who, so the main things to look out for are blurring of vision, or glare is something that a lot of patients will complain of. And glare, particularly when driving at night, they'll see the headlights coming towards them. They're seeing the glare off of the lights. Those are the two commonest things, and difficulty with reading. So near vision becomes very difficult. In terms of the treatment, I always say to my patients, we don't need to do anything until the difficulties that you're having are impacting on your daily life. And that's different for every patient. There will be someone who might be a watchmaker or a jewelry maker, or someone who needs to drive for a living, who needs to have very good clarity of their vision. And so even a slightest bit of cataract is a problem for that patient, and we need to then address that. There might be someone else who, does not have the same visual requirements. And as long as they're able to see the TV and are able to read, large print in a book, they're quite happy. And they probably don't need the cataract operation until later on. So it's really on a case by case, each patient, treated them as an individual and looking at what their needs are in terms of their vision and how their quality of life is affected by the cataract before we even embark on the surgery.
Okay. And Umaima, if you take the story further on, there may be patients out there who are waiting for their operation. Can you tell them what they need to do pre-op and what they can expect post-op?
So pre-op at the moment, you'll probably find that there's a lot of patients out there who have been waiting for the cataract operation and are waiting much longer than they would have otherwise. And unfortunately, due to the COVID pandemic, there's a lot of cataract operations have been postponed. Certainly in our department, we were basically not doing any cataract surgery at all, unless it was, for there's certain, very severe cases. Those are the ones that we're doing, but any elective procedures were not being done. So there'll be a lot of patients who will be, waiting for their surgery. Unfortunately, in terms of trying to do something for their vision, there's not a great deal that patients can do. You can go to an optician, you can see if they can improve the vision slightly with glasses, but often by the time you're being listed for surgery, glasses are not really helping to give you that clarity that you require. Raise back. Things that they can do to help is making sure that the eyes are in a good healthy condition, making sure they're doing the lid hygiene, making sure there's no infections or anything on board, so that when it does come to the operation, we can go ahead with the operation on the day. And then post-op, usually the recovery from cataract surgery is relatively good. It's relatively quick. Patients will often see on the table, as soon as they get up from the operation, they'll notice an improvement in their vision. Practice varies from department to department, but usually you will have drops for up to maybe 4 weeks after your surgery. And it's really important that those drops are going in. It reduces inflammation, reduces the risk of infection. But usually very quickly patients can get back to normal day-to-day things. I know Ray's got a lot of experience with cataracts. I'm not sure if he wants to add more with that.
Yeah.
I've unfortunately dropped out there for a little while because of the internet connection, I think. So I didn't get most of that, sorry.
Yeah, no, we were just talking about obviously what a cataract is, and Umaima's explained that, and obviously it talked about the delay with the COVID pandemic as well to do with cataract operations, and obviously eye drops afterwards and so on. Maybe in your experience, obviously, Ray, you're very experienced and have done a lot of this. Can you tell us a little bit about what maybe the operation involved for patients waiting to have one?
Sure. I think what's changed in the last 20 odd years since I've been doing it is at the beginning, cataract operations took about an hour. The incision was quite large. We had to stitch the eye. Complications weren't uncommon. And we went through a period of my early training where lots of patients would come to consider cataract surgery and they would be really, really scared. And they'd heard a lot of stories of problems. These days, because modern cataract surgery has been going now since the sort of late 1990s, and it's just got better and better. So whilst the complications fundamentally are the same, the risks of complications have got less and less and less. And then with modern equipment and modern lenses, standard cataract surgery, probably for most surgeons, most consultant surgeons, will be anywhere between 15 to 20 minutes for the procedure. If you're a specialist cataract surgeon and you're doing hundreds or thousands of cataracts, then it's possible to get that time down to 10 to 15 minutes per case. And the other big change, and it's still a fear for many people, but less so now, is that whether you use a needle either around or in the eye. In actual fact, most surgery is done now just with drops. So you simply put a few drops on the eye, you check that the patient's not feeling it, The patient's under a little paper tent, they're looking into a bright light, and 10 to 15 minutes later it's done. So the majority of patients now are pleasantly surprised. Cataract surgery is nothing like what people used to hear or even still imagine that it will be. And even when we tell people this and they hear it from relatives and friends, they still don't believe it until they've actually had it themselves. It almost seems impossible that it can be done in this quick way just using drops. It really has changed for the better.
And Ray, just kind of finishing off the topic of cataracts, we talked about what do people need to consider in terms of maintaining good eye health, especially in the sense of cataracts. But what role does alcohol, smoking, healthy diet? It's very easy to say healthy diets, but why are these things important in terms of protecting your eyes?
I think the old adage is as true as it ever was, which is you are what you eat. It really is as simple as that. And if you eat a healthy, balanced diet, like was always been recommended, which is particularly for the eyes, is green leafy vegetables, a very good balanced diet. Drinking a little bit is fine. Excessively drinking can harm your eye. Smoking is associated with optic nerve disease, with glaucoma, with AMD. So cigarette packets now actually have on them that smoking can harm your eyesight, and smoking can lead to losing vision, and that's true. So it really is just the same old advice that we've always had, which is to look after yourself, eat healthily, and don't do anything to an excess. And particularly going back to the diabetics, I was a medical doctor for quite a number of years. And the most important thing with diabetes is to look after your sugars, keep your sugars low, keep your diet good, but also look after your blood pressure. Control of blood pressure is really important.
Yeah, I guess to add on to that, probably obesity.
Yeah,
but
absolutely.
Again, as you said, it's all kind of a holistic picture, isn't it, to maintain a good, healthy lifestyle. So, Umaima, we do have a question from our audience. It does say, how does diabetes affect the eyes? It can be as long as short as you want it to be.
Okay, so diabetes. Diabetes has different impacts on the back of the eye. Basically, there's two different conditions almost that you can get in the eye. Essentially, they come from when you have diabetes, the blood vessels at the back of the eye become leaky and they don't work the way that they should do. This means that there's not enough oxygen getting to the back of the eye. And the body's way to deal with that is so when you've got not enough not oxygen going to the back of the eye, you can get little areas of the retinal tissue that's not working the way it should do, and you can get little bleeds at the back of the eye. If that happens to a severe extent, you can then, the body's response to that is to try and grow new blood vessels to try and provide the oxygen that the back of the eye needs. But these new blood vessels are very abnormal blood vessels, and they're very friable and very weak, and that means that they can bleed very easily. And if that happens, then that can actually cause a lot more damage to the back of the eye. And when I was talking about the screening at the beginning, that's really what we're trying to identify and trying to prevent. The other thing that can happen is that you can have, because these blood vessels are leaky, and because of this lack of oxygen at the back of the eye, the blood vessels can then leak fluid into the central part of the back of the eye, and that's where you get what we call macular edema. So that's fluid buildup at the back of the eye. The treatments for both conditions are slightly different. If you've got the buildup of or the growth of the abnormal blood vessels, the treatment for that is with laser treatment, and many diabetic patients will get that, and that is to reduce the growth of those abnormal blood vessels and to prevent them from bleeding. In terms of the fluid buildup or the macular edema that you can get, the treatment for that is in the form of injections these days. Previously, that was treated with laser treatment historically, but over the last 10 years or so, we found that these injections, anti-VEGF injections that you can get, which are given to the eye itself, have much better results in terms of reducing the fluid and preserving vision. The laser treatment for the fluid can be a little bit destructive to the central part of the eye. So actually giving these injections helps to take the fluid away without causing as much damage to the back of the eye. They're very, very effective, but the treatment course can be very long and prolonged. The initial course of treatment is usually 5 or 6 injections on a monthly basis. So you're looking at 5 or 6 months of injections. And I always say to patients that the key is, even if we're doing all of these things, the key is still the diabetic control, the hypertension control, the obesity control. All of these things are going to contribute to improving the health of the back of the eye. So without doing those things, it doesn't matter how much of the injections we give you, doesn't matter how much of the laser treatment we do, the condition will progress. So it's really important to address both of those factors.
Yeah, no, thank you for that, Umaima. But obviously screening is very important. How is that being managed in the current circumstances in COVID?
So locally here, so the screening service I know the diabetic screening service in Scotland and England is slightly different, but the principles will be much the same. Within Scotland, actually, the screening service, as of March, when we went into lockdown, screening was suspended completely. And it was just the patients that were within the diabetic service, within the hospital service, that were still attending clinics if we felt that they were, urgent enough to require it. But a lot of the monitoring did fall back because, just unfortunately with the impact on the service was that a lot of our appointments had to be postponed. There is getting back up and running. There's probably is going to be a backlog, and I think the important thing is, maintaining good diabetic control, maintaining hypertensive control. That's going to protect the back of your eye as best you can. And if you're noticing any symptoms or any problems at all, then it's important for that to be for you to go and see an optician as soon as possible. The other things that's happening now up and coming is not necessarily during COVID, but up and coming, there's a lot of artificial intelligence coming into the screening service. So actually using artificial intelligence to do the grading. And as that comes in, that will probably help with dealing with the numbers. So that's something that's, going forward will probably become more of a mainstay of the screening service.
Excellent. Ray, we're getting more questions coming in, so you're lucky now. What is Karatokonis, and is there a cure for it? I think that's quite a mouthful. Can you tell us what it is? Because a lot of people may not have heard of it.
Yeah, it's a condition where the front window of the eye, the cornea, particularly in the late teens, it can suddenly begin to distort. It can begin to thin in the middle, and it'll change its shape. So you go from having clear vision and not needing any specs, but then the cornea distorts, and you have a lot of something called astigmatism, which simply means that the cornea is no longer a nice smooth shape like a football, like a sphere. It becomes more like a rugby ball shape. And in the majority of people with early keratoconus, in the majority of people, it's actually quite mild. So you can manage the condition and the effect on the cornea simply by getting new glasses or wearing a lens. But a smaller proportion, I can't remember the exact figures, but maybe 15% or less, it can be more severe to the point where even wearing a contact lens won't help to overcome the effect of the change. And there are treatments now available where they can treat the eye. It's not my area of treatment, but use an ultraviolet light, I believe. But it isn't my area. And if you catch it early enough, you can stabilize the shape of the eye, and you can hopefully stop the cornea becoming this odd shape.
Okay. Maybe something that's more in your area. Presbyopia, Ray, is also obviously going to the other scale now. Obviously, I gather that's more with older people and the changes of aging of the eye. Can you tell us a bit about presbyopia? Yeah.
That's right. So if you've been lucky enough and you're not short-sighted or long-sighted, and there is confusion about them amongst people, short-sighted means you can read without glasses. Even when you're in your 40s and 50s, your focus is very close. But for everyone else who's either long-sighted or normal sighted, so they've never needed glasses, as you get into your late 40s, early 50s, you start to find that you have to hold things further and further away. Your arms have to get longer for you to be able to read something. And what's happening is the internal lens in the eye is becoming stiffer, so you can no longer focus to see things up close. With modern surgery, there's all different techniques to use lenses inside the eye. So when you do a cataract operation, the lens you put in, the power of that lens, you can put any power in, which will determine the focusing of the eye. So you can leave people with good distance vision after cataract surgery. You can leave them with good near vision after cataract surgery. I leave about a third, anything between 25% to a third of my patients with a little bit of both. So one eye has better distance focus, one eye has some near focus, and therefore using both eyes together, they can see distance and near without having to wear glasses. There are other lenses that try to do this. There are multifocal lenses, bifocal lenses, accommodating lenses, lenses which elongate the focus within inside the eye. There's a new design about to hit the market where it looks like a standard lens, but they've changed the center of the lens to give you a bit more near focus that way too. Although it is interesting, in a lot of these technologies, the surgeons will still often end up giving the patient a little bit more distance in one and near in the other to maximize that result. So there are ways now to be able to get people out of glasses as they get older.
Great, thank you for that, Ray. We're getting lots of questions through, so please, if you are watching through our YouTube and Facebook, continue to ask away and we'll try to put it forward to our guests. I know we talked about scans just previously, Umaima. How accurate are they? I guess everyone's very much focused about the accuracy of tests given the current circumstances, and can problems be missed even if scans are arranged? And then what should people do in those situations? So
you mean scans at the back of the eyes, I'm assuming? Yeah.
Yeah, I'm assuming the question is just about, yeah, exactly.
Yeah. So the scan that we do at the back of the eye, it's called an optical coherence tomography, so an OCT scan. And actually the quality of these scans now is remarkable. The technology has improved over the last 15, 20 years to basically you can get what we would call like a histological slice. So you can see in a huge amount of detail and a huge amount of accuracy what is going on at the back of the eye, things that you cannot see clinically. So when we're looking at the eyes, when we examine the back of the eyes, we use quite a strong microscope to look at the back of the eyes. We have various lenses and things to see the blood vessels at the back of the eyes, but even that doesn't really give us the level of clarity that you get with the OCT scans. They're very, very good, and they can show you the most recent versions of the scans can actually give you quite a lot of depth of the retina as well. So you see all of the layers of the retina and beyond. And usually you can pick up a lot of pathology in that. And actually probably the opposite happens. Often now patients will go to opticians and they will get these scans done at opticians. And we probably see a lot more people than we would have done previously because pathology is picked up using these scans, and then they get sent into the hospital for having that examined. And oftentimes actually it's not anything major, it's not anything that requires any treatment, but it's been picked up by these scans because they're such good quality scans. And it's really transformed the way that we work. We would do basically what we call, a lot of our work now through COVID has been through virtual clinics. We see within the medical retina service, our two big areas of conditions that we see are macular degeneration, which is an age-related condition, and the diabetic changes. And all of these can be monitored using these OCT scans. And basically, we've got patients that come into the clinic, they get a scan done, they go home, and they don't see a doctor on the day, and somebody will review those scans later, and we get in contact with them. So it actually eliminates that face-to-face contact. So they're very, very good, and they'll only hopefully just continue to get better. Again, there's artificial intelligence coming into the reading of the scans as well, and that's something that will definitely over the next probably 5-10 years we'll start to see a lot more of that as well.
And just following that, Ray, I take it you've got some understanding and some experience about virtual screening. Can you perhaps just inform the viewers and listeners about how that goes?
It's just some things I've been reading in the articles that are sent out, and also meetings of the last few years. People are now developing instruments that hopefully will be like a virtual reality headset, and you'll be able to put this on, and it will check your refraction, check your vision, scan the eye, look at the layers of the eye, as Umaima was saying, look at the OCT type picture, but also look at the blood supply at the back of the eye. And the idea being these headsets or these imaging systems will then collect a huge amount of data, and as that data gets bigger and bigger, then using AI to interpret all that data, there'll be more and more potential for people to be screened without having to come to the hospital, in whether that is in the high street, in an optician shop, or within a GP surgery. But there certainly is a potential in the future that a lot of the clinical diagnosis will be made in a virtual way, which also means that you won't have to attend hospital. You won't take up hospital time, and only the people with genuine problems which need or could benefit from treatment will be sent. Because at the moment, as Umaima was saying, as each new system comes along, each new modality, people can jump on board and end up sending in things that don't really need treatment. It looks very interesting, but as the technology and the data gets better, then all those things will improve.
Umaima, I want to change tack slightly. We've had an interesting question come through by a listener or viewer, and they were talking about a recent news article about a young lady becoming blind in one eye due to an infection from water when she put in her contact lenses. From my understanding, that would be something called Acanthamoeba Keratitis. Could you tell us a little bit about what was this article, or just this condition, and a little bit about contact lens use? I'm sure that even though two of us are wearing glasses here, a lot of people use contact lenses at home.
So I think I've not seen the article itself, but from what you're saying, it probably does sound like Acanthamoeba Keratitis, which is basically an infection of the cornea, which is the front window of the eye, related to contact lens wear. So Acanthamoeba is present in water. So if you don't use the correct solutions for your contact lenses, if you shower with your contact lenses in, swim with your contact lenses in, anything like this, it can actually put you at quite high risk of developing Acanthamoeba Keratitis. The problem with Acanthamoeba Keratitis is quite a severe infection, and it can be a blinding infection. It's difficult to diagnose straight away. They say that the signs when you look at the eye are often quite subtle, and the treatment, even once you start treatment, can be quite prolonged. The key is really having good contact lens hygiene. Contact lenses are great. Everyone uses them. I wear contact lenses as well, but it's the contact lens hygiene that's the most important thing. You need to have, making sure you're not wearing them for a prolonged period of time. I would say 8 hours, during a day, making sure you've got the correct solutions. If you're using, monthly lenses or weekly lenses, daily disposable lenses are very good because you just don't have to worry so much about the hygiene aspect of it, but also making sure you don't do things like sleep in your lenses, swim, shower. All of these things should really be avoided. And a sign of anything happening at all, if you're a contact lens wearer, you get a red sore eye, you need to get that seen quickly.
Great. Ray, you're one of the glasses wearers on the show. So for those who are listening at home and they're thinking about weighing up laser eye surgery as well, we've got obviously glasses, contact lenses, and laser eye surgery. Can you tell us a little bit about, would you advise them to do it or not?
That's probably used to be the most common question I got asked as soon as someone knew you were an eye doctor. Usually the next question was, what do you think about laser eye surgery? So it's been around for quite some time now. I've never considered it. Most of my colleagues I know haven't had it. It's interesting how it's covered in the press. Usually the horror stories make the headlines of people who've had it and then they haven't got the result they've wanted, because like every procedure there are risks. laser refractive surgery, I know colleagues who do perform the operation and tell me it's got better and better. It doesn't seem to have quite as much press as it used to when it was first around. And I've seen patients who've had it who think it's the best thing I've ever had done, and I know people who've had it done who wish they'd never had it done. So I think if you're thinking of any refractive surgery, because you don't like your glasses or you can't wear your contact lenses, you have options of laser eye surgery. You have options of implant lenses within the eye on top of your natural lens, or you can have a clear lens extraction. So I think the most important thing, if you're going to go down the laser refractive surgery route, is you speak to a consultant who's a specialist in refractive surgery, but also someone who can offer you all the available options. I don't think you should be seeing someone who's biased to do one particular kind of treatment.
So just following on that, Ray, I guess the importance of consent, actually being informed about the real risks as well as the benefits, because there are certain instances, and I guess laser eye surgery is a surgical procedure. A lot of it's not sugar-coated, but a lot of the benefits are put forward, and then people, as you said, come away from the surgery and they really regret it, and then to the extent that they actually didn't know that this was a complication. How much of it is clinician-led? How much is the patient-led in terms of deciding things like laser eye surgery?
Well, I'm not involved in the area at all. I'm not a refractive surgeon, but laser eye surgery is something you have to pay for. It's a commercial practice. So the lasers, certainly when I was aware of it, were extremely expensive. So if you set up a laser eye service and you buy an expensive laser, then you obviously have to use the laser to justify buying it in the first place. And clearly, if you're into marketing, you're gonna publish the best possible aspect of it. Having said that, if you go for laser eye surgery, I'm sure you are given an extensive consent form with all the risks there for you to read. And I'm sure you are told all those things. You'll be asked to sign the form. But as I said just a few moments ago there, the important thing is to see someone who can offer you every possible option. And therefore, they're putting your best interests at heart.
Yeah. And just moving on, we are still getting lots of questions, so we will try and cover those as time progresses. But the other huge topic, Umaima, is about glaucoma. And coming from a old-age psychiatry perspective, this is something that we do commonly come across, as well as their kind of psychiatric manifestations of their visual disturbances. Could you tell the listeners and the viewers a bit more about glaucoma, what to look out for in terms of the initial signs and symptoms?
So glaucoma is basically damage to the nerve at the back of the eye, because of high pressure in the eye. There's lots of different things that can cause glaucoma, but the commonest one is what we call primary opening glaucoma, where you just have this buildup of pressure. The drainage of fluid from the eye is not as good as it should be. That puts pressure on the nerve at the back of the eye and can cause damage. I think Ray had mentioned at the beginning, one of the things that kind of almost needs screening within the community, and it's one of the things that opticians will always check for. The difficulty with glaucoma is that the vast majority of it is asymptomatic. So patients won't know that they have it. It comes on very, very slowly. It will affect your peripheral vision. And you could go for years without even knowing. There's an estimate that probably about 50% of glaucoma is undiagnosed in the community. And so the optician checks are really, really important for that. If you do get sent up to the eye clinic for assessment of glaucoma, you get diagnosed with glaucoma. As I said, there's different causes for it. I'm just speaking about the most common one. In that, often you'll be started on drops and treatment. These drops, again, you don't notice any changes. You don't know, because you've not noticed a problem in the first place. You won't notice any changes using the drops. But it's really vital to carry on using those drops because they are helping to slow down the progression of the condition. as glaucoma progresses, basically it constricts your visual field, and you end up with almost tunnel vision. So you have this very tiny island of vision that you can see through, and you can't see anything in the periphery. That can obviously be very, debilitating. And you mentioned in terms of psychiatry, one of the things that you can get in any condition where you have a significant loss of vision, and that can be, it can be glaucoma, it can be macular degeneration, it can be vascular problems, it can be diabetes, but you can get a condition called Charles-Bonnet, and that's basically where you have where it's almost like a phantom limb type condition, where the mind starts to see patterns or people or colors or pictures or makes up an image. Because the eye is no longer seeing, it fills in the gaps and it tries to show you something from that eye, and that way you start to see things that aren't necessarily there. Now, it's not really a psychiatric issue. It's just the fact that the eye is creating these images. And often just giving the patients, explaining to patients, this is what is happening and this is why it's happening, is enough for them to learn to accept it and learn to live with it. And sometimes it can just go away, even just knowing what it is. It's just frightening for patients when they don't know why this is happening. And a good explanation just gives them that support. It is common, and it's probably not explained often enough within eye clinics. But there are support services out there and things for those, and there's always worth asking about it.
Yeah, and I think there is a risk of being put on antidepressants, as well as because of the symptoms can be quite distressing. They may need additional kind of mental health services involvement. So it's, as you mentioned, it's a very difficult thing, but insight is quite important, and they do appear to have that degree of insight in terms of the visual disturbances and what it means. Go on, Ray. You're about to say something.
I was going to say, I've met a lot of people who have Charles-Bonnet, and what's interesting is how many, when you give them permission to talk about it, because they have poor vision, and then you say to them, I'm going to say something very odd, but have you ever had any of these strange things happen where you've seen people or animals, or you've been quite alarmed by things? And it's amazing how many people will suddenly look at you, realize that maybe they can share this with you, and then tell you all sorts of amazing stories of things that they've seen, the most bizarre things. And like you just said, it's giving them permission, that space to talk about it. And also people who do have AMD or advanced glaucoma, I always try to remember to warn people before it happens. Say this could happen. It might sound very strange. It probably will never happen. But if it does, it doesn't mean you've lost your marbles, something's gone terribly wrong. And it isn't that uncommon. I think that's really useful.
Umaima, I know you wanted to speak about AMD, so let's squeeze that in at this stage. Obviously, that's just the acronym or the abbreviation for age-related macular degeneration, and that's quite common, affecting the middle part of the vision. Tell us a little bit more about AMD and how it presents to people.
So AMD is age-related macular degeneration, and it's the leading cause of blindness in over 50s. There's two types of macular degeneration. There's a dry type and a wet type. The dry type is where you get slowly progressive age-related wear and tear changes at the back of the eye. It's just the back of the eye doesn't work quite the way it should. And it affects the central part of the eye. So patients will often notice that the central vision becomes blurred, it can become darker, it can become a little bit distorted. The other type of macular degeneration is the wet type of macular degeneration. It's a similar process. You've got these wear and tear changes, but on top of that, you then get fluid buildup, and you can have bleeding at the back of the eye. When you have that can cause a much more sudden, much more dramatic drop in vision. Again, the symptoms are similar: a dark patch in the central vision, distortion, or blurring of vision. Distortion is one of the key things that we look for. If you have the wet type of macular degeneration, that can be treated with injections, similar to the injection, in fact, the same injections that you would treat diabetes with, diabetic maculopathy with. The injections are given to the eye itself, you get 1 injection every month for 3 months, and then we follow you up. The very good results from it, and it helps to stabilize the vision. So it helps to stop any further deterioration. We often say that we won't necessarily be able to regain vision, although a lot of people nowadays do actually, recover some vision, but the aim is really to stop it from getting any worse and to stop you from developing big bleeds at the back of the eye. The other big thing with macular degeneration is, lifestyle factors can affect that. So making sure you have, as Ray mentioned at the beginning, lots of leafy greens, a good, healthy, balanced diet, stopping smoking, UV protection. So using sunglasses with good UV protection that can protect the back of your eyes. All of these things can help. And then the other thing is the social support. So blind registration or partial sight registration. There's lots of patient support services. There's the Macular Disease Society. There's the RNIB. All of these societies help to provide the social support that these patients need. Often they're blinding conditions, and patients will need that support. But there's a lot of networks out there. You just need to speak to the right people. Speaking to your optician, speaking to your eye doctor, and there's lots of access there.
Excellent. Ray, I want to tackle one other clinical topic, I think, before we start rounding up tonight, and that's to do with the myopia epidemic, so to speak. We're obviously in a coronavirus pandemic, but can you tell the listeners and viewers about this condition, short-sightedness, and perhaps the correlation with our lifestyle of using computer screens and time online, so on?
So we've been known for some time that in the Far East, particularly in China, that being short-sighted is extremely common. And we weren't clear whether this was because traditionally the Chinese are working very hard and doing lots of studying. But it turns out it's almost certainly true. And in children who are not getting outside, not getting ultraviolet light, and spending a lot of time increasingly looking at screens, working up close all the time, it just does drive a degree of short sight. And it's happening all across the world now. So the advice is for parents is to, even though it will make you extremely unpopular, is to get your children outside and playing sport and playing on their bikes and playing in the park, and actually limit the time they spend on screen. They probably won't thank you when they're little, not so much, but they certainly will when they're older.
Great. Just want to put some feedback. We're getting lots of viewers and listeners' comments. So that's from Abdul Razak, just complimenting you both, and I guess for ourselves. But it's just, it's a really fascinating discussion. Lots of things to cover, and then there's also for Sadiq. So it's clearly, it's a very important topic. So I guess we're coming towards the end of our show. Umaima, I'd like to get your 3 tips. We do have this kind of tradition. So any guests to try and share those important 3 areas for viewers and listeners.
So I said my 3 tips would be, one is to make sure you go to your optician on a regular basis and get your eyes tested. As we've mentioned, there's a lot of eye conditions there that are, they may not have many symptoms, and they will only be picked up by seeing your optician. So it's really important to do that. Usually that's once every couple of years, and your optician will let you know if that needs to be any more frequently than that. The second thing is, we touched on the screening, and it's really, really important making sure that if you are within the diabetic screening service, that you're attending your optician, your screening appointments on a regular basis, again, so that we can pick things up sooner rather than later, and treat them as appropriate. And the third thing is, really during this COVID pandemic, I think we had seen a decrease in the number of referrals or even patients presenting with things like retinal detachments. That's not something that we've actually managed to cover tonight, but retinal detachments, again, it's a sight-threatening condition, and we saw a decrease in the number of presentations. There should be no reason for that, and it's like they say with lumps and bumps and heart attacks and strokes and all of these things still present, and make sure that you do go and get seen if you've got symptoms where you've lost your vision, you're complaining of distortion. If you've got a very painful red eye, you must get seen, because you could have an irreversible sight-threatening condition that needs to be treated sooner rather than later.
That's great. Thank you for that, Umaima. And Ray, over to you in terms of your 3 tips.
Probably first one would be in my area. If you're getting cataract symptoms, and it's often the commonest ones are you're struggling to drive at night time, you're getting glare and halos, you're unable to look at your phone and read as easily anymore. Cataract surgery has improved a great deal, but there's still a huge number of people who are terrified and will present late in their 80s and 90s when the cataract is actually quite dense now. And whilst it's still perfectly possible to do surgery at that stage, it's actually safer to have it done a little bit earlier than that. So it's worth discussing with your optician. The second one would be what we discussed with the Myopia Epidemic, is to get your kids out, although it might make you unpopular. And probably the third thing is back to the dry eye disease and irritable eyes, all the symptoms we talked about. It's just to do that simple test yourself. It's just to shut your eyes, wait a few minutes, open them and stare, and see if it reproduces the symptoms you were complaining about, because there's a good chance that is all it is.
Excellent. Good. So we've had the 3 top tips. We've got a couple extra minutes from our producer. So Ray, I'm going to give you a chance to plug your book and your website and maybe even your private practice. Go on. You got a minute off the floor.
Well, I did write a book a few years ago, rather controversially called NHS Please Don't Kill Me. It was written after the controversy in Staffordshire Hospital. But the book is actually a book to help patients ask the right questions when they see a health professional, so that they go in prepared and actually ask the questions they've been thinking about for months, which when they get put in front of a doctor, they often forget to ask and remember when they get home. So it's a very useful book in terms of preparing when you're ill, and feedback from people who've been to a hospital and unfortunately been ill was, it's often, I wish I'd had that book beforehand, but people aren't very proactive about preparing to see a doctor. My experience is most people go in, hope that the professional will do the best job they can, and most professionals absolutely do that. But you can't beat being prepared before you go.
Excellent.
I think
your website, Ray, your website?
So the website is Dr. Ray at drray.co.uk. There's a current website out. There's a new website coming out soon, I hope, which will have lots of information about most of the conditions we actually talked about tonight.
Great, thank you for that, Ray. I guess for all the viewers on our social media platforms, if you've enjoyed what you've seen and heard, please do subscribe to our channels. We'll keep coming on every Tuesday evening from 8 to 9, bringing a range of topics. But I'd just like to thank again Dr. Mayama Muller and Dr. Ray Radford for their expertise and enthusiasm in terms of this topic. So thank you.
Very much. Thanks for the invite.
Thank you very much.
Thank you both, and have a very good evening. Thank you so much.
Okay. Take care.
Thank you.